All right, good evening. 6 o'clock. We're gonna start with just two of you guys. So I guess it'll be a full night. It's a big chapter, so that's why we're gonna start on time. Going over geriatrics tonight. We're gonna talk about special populations, applies the fundamental knowledge of growth, development, and aging, and assessment findings to provide basic emergency care and transportation for a patient with special needs. So geriatrics impact an age-related change on assessment and care. Let's see here. We're going to talk about changes associated with aging, psychological effects of aging, age-related assessments, and treatment modifications for the majority of common geriatric diseases and emergencies. We'll cover about cardiovascular disease, respiratory disease, and neurologic diseases tonight. We'll also go over endocrine diseases, Alzheimer's, dementia. We'll talk a little bit about how we report abuse, kind of the same thing that we have for pediatrics like we did the other night. And then we'll talk about some geriatric neglect. For the last time, I'm going to say it for this entire class. Trauma applies the fundamental knowledge to provide basic emergency care and transportation based on the assessment findings for an acutely injured patient. All right, so special considerations in trauma. So what do we know about geriatrics? We know that things slow down. We know that they are older. Their reaction speed is a little different. So trauma injuries in geriatrics are going to be much worse. They have poor perfusion. They have poor clotting methods. They may be on like a fluid pill. They may be on a clotting pill because they can't clot blood real well. So all of those types of traumas are going to be really rough. We know that the pathophysiology and assessment and management of trauma is going to be very different for geriatric patients because of the things are going so fast. Their process mode, the way that they're just going to process everything is going to be a little bit slower. So we're going to have to take our time, but we're still going to have to work fast. So geriatrics is the assessment and treatment of diseases in a person who is 65 years or older. It's projected that between 2012 and 2050, the population aged 65 years and older is expected to double. Geriatric patients present as a special challenge for healthcare providers because the classic presentation of injuries and illness are often altered by the presence of chronic conditions, multiple medication, I'm going to say quadruple amount of medications, and physiologically of aging. So it is important to understand and appreciate how the life of an older person might differ from yours. We're going to say, like, for example, look at their hearts. We'll go from pediatrics to middle age to geriatrics being 65 or older. So the hearts are completely different. You have a new one that's learning to pump right, that's pumping super fast. You move into the middle age, they're starting to slow down, their blood pressures are starting to be about the same. And then when you get into the geriatrics, the heart is just like any other part of the body. It wears out too. She starts having trouble beating and then she just wears out. At some times we have to have things replaced. Let's say like our knees, we'll replace our knees. Geriatrics are not points because they've done so much in their times in their lives of 65 years of doing things happen to wear out. So we know our treatment is going to be a little different. We're going to have to be more patient with them. We're going to may have to explain ourselves a little bit more and or speak louder or try to figure out a different way to speak with them so they understand a little bit better. Like every attempt to avoid ageism, the stereotyping of older people that often leads to discrimination. Older people can stay fit and be active, even though they are not able to perform the same level as they did in their youth. My grandmother is 90 years old. She does not look it. She looks about in her 60s, maybe 70s. She moves super slow, and she'll tell you she moves super slow, but her hearing is on point. You can't whisper about her. She can hear it. She still drives herself. She still flies back and forth to California to see her son on her own. So she's there. It's just she's just a little bit slower. So we can't say that things like that are all going to slow down. Communication with older adults. We know effective verbal communications. We have to do those. We We have to think about how challenging those are. We know that sometimes they're hard of hearing. Changes in communication abilities accompanied with age, such as dementia or other diseases. Communication techniques, when caring for older individuals, use their name to communicate with them. Don't say, hey, sweetheart, or hey, excuse me, sir, or hey, buddy, you know, oh, pal. They using their names because they know that that is something that they can respond to a lot easier. Ask the patient how he or she refers to be addressed and can build you trust with them. When you interview or try to build your assessment with these elderly patients, identify yourself, be aware of how you present yourself, look directly at the patient at eye level, and ensure that you're paying attention to them. Listen to what they have to say and speak slow and distinctly, because that lets them, they're able to hear the same tone a lot better than you speaking really fast and you try to that just doesn't work for the elderly. So we have to slow down. We have to process things a little bit easier for them so they can understand and communicate effectively back to us. Have one person talk to the patient and ask one question at a time. Don't have both providers or both EMTs. Y'all hang on one second. I got to answer a text. All right. So let them have those one questions at a time. Answer them. Allow them to answer those questions. And when they answer you a question back, answer them back too. Explain what you will do before you do it. Let them know, sir, listen, I'm going to check your blood pressure. We're going to put this thing around your arm. It's going to get kind of tight. It's going to tell me what your blood pressure is. Do not talk to the patient and do not talk about the patient in front of them, even though and you're acting like the patient's not there. That's just complete disrespect, not allowing them to understand or potentially speak for themselves. Now, granted, they may not be there, or they just physically may not, but they're mentally capable of understanding. So make sure that you speak to the patient, but look at the family and say, hey, did what Mr. John say, is that what you guys have seen at the same time? So that allows that you're listening to them, but also confirming what they say. Some common complaints and leading causes of death in elderly patients is the change in the psychologic of geriatric patients can predispose the population of a host of problems. A simple rib fracture in an 80 or 90-year-old can result in pneumonia, and that potentially is going to take them to death. A hip fracture from something that's a low impact or a fall is common in elderly people, and that may also have a dire consequence. Hip fractures are more likely to occur when bones are weakened by osteoporosis or some type of infection. Sedentary behavior while healing can predispose the patient for pneumonia and blood clots again. Many older patients who experience hip fractures do not return to their pre-injury level of activity. That's just something that they just don't return to because those muscles are already weak. And now that they've set there, they just become that much weaker. So here's a chart that shows about some complaints that are leading to cause of death of elderly patients. We talk about some common conditions. Then we talk about leading cause of death. Obviously, you see hypertension, heart disease, diabetes is a big thing, strokes, chronic bronchitis can also turn into pneumonia. So all these conditions can affect them in a very ill manner. And we lose a lot of good elderly people because of just small, simple injuries or simple issues that their bodies just can't heal from. So human growth and development peaks in the late 20s. That's kind of once you're at your part, and to the early 30s. And then you start aging. The aging process is inevitable. You're not going to run from it. You're not going to hide from it. and is accompanied by psychologic functions such as decline in the function of their liver and kidneys. All tissues in the body undergo aging. You're not going to run from it. The decrease in the function of capacity of various organ systems is normal, but can affect the way in which a patient responds to certain types of illnesses. Age-related changes can predispose an elderly adult to respiratory illness. Weakening of the airway musculature can cause decreased breathing capacity. Alveoli can become enlarged, and elasticity decreases, making it very hard to expel air, so they may have a trapped air at times. Chemoreceptors slow with age, causing the body to respond more slowly to hypoxia. And then a loss of mechanism that protects the upper airway, including decreased cough and or gag reflection. Pneumonia, that's a big one, man. That takes a lot of elderly patients. Chronic lower respiratory disease, it's an influenza and pneumonia are in the top 5 categories of geriatric death. Inflammation, infection of the lungs from bacterial, viral, or fungal causes is one of the leading causes of death from elderly is an infection. Aging causes some immune suppression and increases the risk of contracting infectious like pneumonia. As you see, there's a pattern there of building up pneumonia. Pneumonia is the more that they sit there, the more they're unable to expel the fluid or the air. It's the more common that they are to get pneumonia. Increased mucus production, pulmonary secretions, and the inflammatory effects of infection all interfere with the ability of the alveoli to oxygenate. Management of pneumonia is the same for any patient. However, maintain a high index of suspicion for any geriatric patient with signs and symptoms of pneumonia. All right, so a PE, we're going to talk about a pulmonary embolism. They cause sudden blockage of the artery by a venous clot. A patient with a pulmonary embolism will present with shortness of breath and sometimes chest pain. This can be confused with a cardiac, lung, or musculoskeletal problem because of where they complain of the pain or discomfort from. That's why that you may get it confused. Living in a nursing home or recent hospitalized is a huge risk factor. Trauma, some recent cancer, history of blood clots or failure, the presence of a pacemaker or central or venous catheter, some type of paralyzed extremity, obesity, some type of smoking, and recent long distal traveling will increase a PE. I tell you what, I used to travel back and forth across the Middle East. I, at my age, would still wear those compression diabetic socks just because I was seated for greater than 13 hours. Yes, you could get up, move around, go to the restroom, but at the same time it was safer than sorry for us to just take that extra precaution and buy those socks. So recent travel in elderly patients will and can produce, it's not going to always produce, but it can produce a pulmonary embolism. Patients that present with any of these, tachycardia, sudden onset of dyspnea, shoulder, back, or chest pains, some type of cough, a syncope in patients with whom the clot is larger, and or anxiety, and some more. You have apprehensive, low-grade fevers, hemoptysis, leg pain, redness, and unilaterally pedal edema. So in other words, both legs are going to be swollen. They're going to constantly have chronic fatigue, or cardiac arrest does worsen this complete scenario. Treatment should focus on airways, ventilation, and circulatory support. You're going to go into oxygen supplemental oxygen and ventilatory. When we start bagging for them, that's probably going to be a need, not necessarily a request or a must, but making sure that you have it ready and available is the most important thing. Changing the cardiovascular system. We talked about this just a second ago. We know that that's going to happen due to age, due to a bunch of other things. is going to have some issues there. So the heart hypertrophies with age, probably in response to the chronologically increased afterload. And it does have some predisposed stiffening of the blood vessels. Over time, the cardiac output declines mostly as a result of a decreased stroke volume. Arteriosterosis continues to systolic hypertension, which places an extra burden on the heart. They like these big old words. Whew. Anatomy and physiology. Let's see here. It didn't change. Why did it not change? All right, so the ability to speed up contractions, increase contraction strength, and constrict or narrow blood vessels is decreased because of the stiffer vessels. They become harder. They have a lot of plaque buildup. Over time, those vessels just become super hard. So cardiac output declines, mostly as a result of a decreased stroke volume. They're not able to flow that blood because of the stiffer vessels. Arteriosclerosis continues to systolic hypertension, which places an extra burden on the heart. So look at this picture right here. So you can see that, let me make sure. So you can see this is all normal through here. That's all the flowing water through all the cells and all that. So this now is very bad because what's happening is you have your cholesterol. That's why we want to make sure our cholesterols are right. Now we've got all these, the lumen that has built up on the inside. It's got a little thick. Now we have a calcium buildup now, and then we throw on top of all of that, we throw a blood clot in there. So now we're looking at multiple different things that's causing issues. That's all with age. Now, again, medication does assist with reducing all that, but you got to go to the doctor. You got to be adamant about going, and you have to take the correct medication that's prescribed to you. You can't just go and not take it because eventually unfortunately, you're gonna pass because your heart just has nothing to pump. The older people who are also at an increased risk from the formation of an aneurysm, you have some severe blood loss can occur. The blood vessels become stiffer, which results in a higher systolic blood pressure, stiffening and degeneration of the heart valves that may impede normal blood flow in and out of the heart. So I was talking about, now you're not flowing that blood because of that. The electrical conduction system of the heart undergoes changes, which is also leading to the abnormal rates and rhythms. Their electrical system is wearing down. They're tired. So the orthostatic hypertension is a drop in blood pressure with a change in position. So if they're sitting and their blood pressure is fine, and then they stand up, they're like, wow, I'm so dizzy. We'll check their blood pressure as they're standing up, and I guarantee you it's bottomed out. So we have to be very cautious of that. And the body is less able to adapt to a rapid posterior change. So now, well, I can say my age. If you get up real fast and you're like, whoa, what was that? Unfortunately, I've been on blood pressure medicine for the last 3 years. I wish that I wasn't. Probably need to lose some weight, be a little bit more healthy, but I like food. That's part of my problem right there. Those things happen the older that you get. And that's just something that we're not used to. It's hard to get around. It's hard for us to say, okay, I'm gonna do this, this, and this, because things change and times get busier. The venous status can cause clots to develop in the veins. This leads to the development of vein thrombosis or pulmonary embolisms. Some loss of proper function of the veins in the legs that would normally carry blood back and forth. So again, you get this swelling in the legs, you get their legs that are swollen. So you start recognizing that there's a fluid retention. And now that they're swelling, it's putting some pressure in and or on the blood flow itself. So myocardial infarction is the classic symptoms of a heart attack are often not present in a geriatric patient. As many as 1/3 of older patients have silent attacks in which the usual chest pain is not present. This is unfortunately more common in women and with patients of diabetes. So the silent heart attack, I can tell you one here straight up. I went to a responded to a 65-year-old female, says that she just a little, she couldn't cool off. That was the call. And it was, August, late August in Mississippi. Go there, 65-year-old Black female, super nice, had a wonderful, like, I will never forget this lady. She was amazing. Learned a lot from her. Learned a lot of food things too while I was with her. But the silent heart attack majority happens in Black females of age. They never, ever will show signs of a heart attack. That being the case is I just took her for what was going on. She didn't sweat. She wasn't showing. She said she's just super hot. Okay. So I was like, baby, do you mind if I put you on the monitor, check your blood pressure, see what's going on? Literally, as soon as I put her on the monitor, I recognized she was having a STEMI. I was like, man, her blood pressure was a little off, but nothing like that would cause some attention. But this lady was actively having a heart attack in front of me and never knew it. She didn't have the original chest pain. She didn't have the, pain to the left side of my jaw. She didn't have any of that. And that has been more Black women 65 or older will not show signs of symptoms. So I preached that when we started talking about elderly, geriatrics, in females, especially the Black females, be very cautious when you go to those and they're just saying off the wall things that just doesn't add up. Have your partner just say, hey, let's run a quick 4-lead if you don't mind. I want to study these 4 leads. It may open up the basket for bigger things and we're not realizing that we're missing something. Some signs and symptoms of a cardiovascular disease. We'll talk about confusion. We'll have severe fatigue, nausea and vomiting, loss of bladder and bowel control. You'll have some abdominal pain and obviously dyspnea, like we've gone over several times before. Some other signs, you'll have diaphoresis, pale cyanotic or molted skin, abnormal or decreased breath sounds, increased peripheral edema. You should see that in their feet and or their hands or legs. Administer aspirin or assist the patient to administer nitroglycerin. Those are the things that we can do depending upon your state and or your protocols. If the patient has nitro, please make sure you help them take that. That will benefit them and you for transport. Heart failure is the signs and symptoms will differ depending on the extent to which the right and left side of the heart is not functioning correctly. One of those is either an offbeat, they're throwing different signs like heart rhythms, they're just not maxing up like they're supposed to. A right-sided heart failure occurs when the fluid backs up into the body. You will see a jugular vein distension associates and peripheral edema. An enlarged liver may also be present, which is determined by palpitation. Right-sided heart failure is often caused by left-sided heart failure, so it is common to see signs of both. So if ever nobody knows, I'm just not no means I'm testing nobody's smartness, but a extended JVD is the vein that's in our neck. You'll see some that are super big on people. I'm a little bit thicker, so you don't see mine, but you see the ones that stand out. Theirs is very distended, like they have a lot of pressure buildup in there because you're having a right-sided heart failure, and you see that builds up on the JVD. So be attentive to those. Look at the patients that have the JVD, and when you see it, go with it and try to learn things. When a left-sided heart failure fluid backs up into the lungs, this causes pulmonary edema of shortness of breath. Severe shortness of breath or hypoxia, crackles in the lungs. Hey, did y'all have any trouble getting into the class? I just see that come through on Discord. So again, here you want to make sure that you listen to the lungs, listen to every patient that you come across. And the reason why we tell you that is so you can continue to learn lung sounds. The ability of learning these lung sounds are very beneficial to you. Hearing clear lungs, understanding of why these lungs sound like that, those are super important too. Proximal nocturnal dyspnea is characterized by a sudden attack of respiratory distress that wakes the person at night when he or she is reclining. This is caused by fluid that accumulates in the lungs. Some signs and symptoms include coughing and feeling of suffocation. You'll have cold sweats, maybe have a racing heart. Let's see, treatment consists of airway ventilatory and circulatory support. So here's you a telltale sign of this right here. If you go to the patient and they're sitting in their recliner at 2:30 in the morning or during the day, and every single thing that is required for them to exist is surrounding them. That is because they feel uncomfortable or have trouble sleeping at a reclined position, so they sleep in their recliners. Yes, it sucks. That is caused by the fluid buildup. When they lay flat, the fluid comes up higher into the lungs and they can't breathe. A lot of times later in life, people will buy the incline, the inclining beds or the elevated beds, so the heads can elevate and they can sleep comfortably. It's just some little side tricks that you may see. So a stroke, a leading cause of death in elderly people. This is a preventable factor, but smoking, hypertension, diabetes, AFib, obesity, and a sedentary life, they don't really help us. And we got to control those things. We got to make sure that those are not a factor. Some other things that you cannot control is age, race, and gender. We said that majority of sometimes is more prominent in females. So that is why we add that into there. Some signs and symptoms include acute altered mental status, consciousness, numbness, weakness, or paralysis on one side of the body. You may see slurred speech. You may have aphasia, which is visual disturbances, headaches, dizziness. They may urinate on themselves. And in worst case, you may see a seizure when it comes down to a stroke. A lot of times the aphasia and the weakness on one side is gonna be what you see majority of the time. I suffer from chronic migraines, but when I was going to get on certain medication, I couldn't tell you how many CTs I had just to make sure that I didn't have a clot or I wasn't having a stroke. I mean, I went through a lot of things just to try to prove so I could get on some medicine. Some hemorrhagic strokes, in which is a broken blood vessel causes bleeding into the brain, are less common and more likely to be fatal. And those are the ones that happen to just go to sleep and don't wake up, and or it's very fast. Ischemic strokes can occur when the blood clot blocks the flow of the blood to a portion of the brain. And when that happens, portions of the brain start dying pretty rapidly. They may not gain actions of certain parts because of what area the stroke and the bleed was on. Determining the onset and symptoms of a stroke is very important. If the symptoms occurred within the past few hours, a patient will be a candidate for a stroke center therapy. A transient ischemic attack can present with the same signs and symptoms as a stroke, but always manage the patient as if he or she is having a stroke. So there's not a lot of things that we can do in the field for a stroke, but we can do a rapid transport once we start recognizing and realizing that they're probably having a TIA. We can get them to the facility a lot faster. And changes in the nervous system. So let's think about this. So changing in the thinking speed, their memory, and the posture stability, it's kind of one of the common normal findings in elderly people. They don't remember as much. They're a little bit slower. They do slump over. They don't have the muscle mass to kind of hold them upright. So their brain does decrease in terms of weight. It's 10 or 20% of volume as a person ages. This is increasing the amount of space in the cranium and increasing the change for head injuries. So there's about a 5 to 50% chance loss of neurons in elderly people. Think about that, y'all. That is a lot. So 50% of neurons that we have right now are gone by the time we reach 65. That's just mind blowing. That's scary. So hearing those things makes you like, oh, I want to start doing this. Well, we don't ever continue the process, but so now that you know that they're starting to say, okay, well, why am I getting a lot of these geriatric patients with head traumas? Well, remember what it just said. Whoops, sorry. There's a 10 to 20% of volume that opens up in the patient's head. So now there's that much more space for them to create a head injury where bleed is going to turn around and blood's going to fill that space up from a bleed. So it says the performance of most of the sensory organs declines and the aging increases. So obviously vision, oh man, my eyes are killing me. So visual acuity, depth perception, and the ability of the eyes to accommodate the light changes with age. Characteristics interfere with vision and makes it more difficult to distinguish colors and see clearly, increases the likelihood of falls and medication errors. Well, okay, so the depth perception, we get that. We kind of understand that. That creates the falls a little bit more because they didn't see that step. That step looked like it was a little bit further off. You have some medication errors, again, because they can't see properly, like because they probably hadn't had their eyes checked in a good amount of time because being on a certain type of budget, they may can't afford new glasses. Those are all the things that you have to think about. You have decreased tear production, leads to drier eyes. A lot of elderly will carry around eye drops because of that, or either constantly have red eyes. So all those things are potential issues that we're going to increase. Now, they may not call you a 911 call and be like, oh, my eyes are so dry, I need some help. I don't really know what you want me to do for that, sir, but you may not see those types of calls. So older people develop an ability to differentiate colors and have decreased night vision. So the inability to see close is called presbyopia and is caused by a loss of elasticity of the crystalline lens. Now, I'll tell you now, and I'm 40 some odd years old, I can tell you right now, I don't have good vision at night, even with my glasses on. I turn around and kind of refuse to drive in the evening because of that particular reason. It's harder for me to see. Some elderly patients become down with glaucoma, macular degeneration, and retinal detachment. So those are more common in elderly patients too. Those are all kind of serious injuries too. So hearing, we know that geriatrics just can't hear. So changes in the inner ear make hearing higher frequency sounds difficult. Changes in the ear can also cause problems with the balance and make falls more likely. Prebiscus is a gradual hearing loss. Hereditary and long-term exposure to loud noises are one of the main factors that contribute to a hearing loss. When assessing your patient, check for the use of hearing aids. I don't know if I told y'all, but like my grandma's hearing aids, they're super cool. They connect to her phone. They can connect to her TV. So like you always walk in there and you're like, why are we watching their lips move? Well, they're not. She's able to hear it through her hearing aid. And now it doesn't affect her from hearing things going on in the house. She's able to control it if she wants to hear it or not. So that's just something that's pretty cool. So always check for those hearing aids. I don't know if you're aware, but our taste buds, they change about every 7 years. There's things that you may like now that you may not like in a couple of years, or things that you didn't ever know that you would like, you're liking now. With that happening, you start to get into the malnutrition because they're afraid that they can't eat certain things, things that they've liked for years, they just don't eat no more because that's what they always ate. You can have fatigue because they're low of the carbs, the sugars, and then they're granted weight loss because of the decrease in the number of taste buds because it's It just don't taste good to them no more. That's why. Touch, decreased sense of touch and pain receptors from the loss of the nerve fibers. The older person may be injured and do not know it. Decreased sensation of hot and cold. They may have a skin tear, or to us, it really wouldn't bother us, but a skin tear is going to cause them to bleed more rapidly and them just not know what's happening or what's going on. So that's probably why that you may see the several bruisings or tears that go on, that they just have no idea what's going on because they just didn't feel it. They didn't know what was up. So some things about dementia. So this is the slow onset of progressive disorientation, shortened attention span, hell, I have that now, and the loss of cognitive function, a chronic general reversible condition that causes progressive loss of cognitive abilities, psychomotor skills, and social skills. They just retract. Everything retreats and they just become more of a loner. Potential causes include Alzheimer's disease, Parkinson's disease, stroke, and some genetic factors. Determine the patient's normal mental status by questioning the family members or friends. Evaluate history, some risk factors, and some current medications may be causing those things. But you can say, like, is this Mr. John's normal response when he asks questions? Is this how he normally responds? And they're like, no, that's when we called you. Just these things are just not coming out like they should. And that's just, okay, that gives you a sign. Okay, maybe a stroke, maybe you can have a bleed, early signs of Alzheimer's or dementia. So that's some of the things we have to ask. Now, again, don't talk around the patient again, but understanding that we have that ability. So we need to just do a good assessment. The patient might exhibit loss of cognitive function. Patients may have a short and long-term memory problem and a decreased attention span, or they may be unable to perform certain types of daily activities. They may also show a decreased ability to communicate and appear confused. They're not sure what's going on. They're just having trouble grasping things. They don't know who you are. They may not know somebody else in the room. They may be scared. So think about all those things as we start to deal with these patients. So delirium. This is a sudden change in the mental status. They are consciousness and they have cognitive process. Those things change. So when we notice that they have a change in those three, we can start figuring out. So is this the inability to focus? What are we thinking outside of the box? They're just radically responding to things. This does affect about 15 to 50% of hospitalized people older than the age of 70. I don't know why that is, but you start to see more elderly patients that spend a longer time in the medical facility, hospital, assisted living, or the long-term care. They develop delirium. Their mental status changes and they resort to certain types of changes. Usually the result is irreversible. It's a reversible physical ailment such as tremors, fever, or the metabolic cause. An important thing to look is in the history. Intoxicated or withdrawal from, they may be intoxication or withdrawal from alcohol. They withdraw from sedatives. Trying to, another message. Medication conditions such as they may have a UTI. They could start having a bowel obstruction. They could be severely dehydrated, have fever, cardiovascular disease, some hypoglycemia or hyper, and they could be some environmental emergencies. Stand by a second. So assess and manage for treatment. So we can treat those 4 things right there. We can treat the hypoxia, hypovolemia, hypoglycemia, and hypothermia. We can do stuff about those in the back of the truck. We can do those. You may see changes in circulation, breathing, breath sounds, motor functions, and eye functions. So we can fix those, and those are some of the signs and symptoms. So recognizing those early signs can help us treat patients and understanding things and try to make them better. So let's talk about syncope. It's always assumed that it is life-threatening. Some of the problems until proven otherwise, often caused by an interruption of the blood flow of the brain. So we know that they just pass out. So we see right there, you can see some causes and descriptions. Y'all read that real quick. I'm gonna get me a drink of water. Breaking just a little bit. I haven't forgot about y'all, I promise. Okay, there we go. All right, so a neuropathy. This is a disorder of nerves of the peripheral nervous system in which function and structure of the peripheral motor, sensory, and automatic neurons are impaired. Symptoms depend on whether the nerves affected are motor, sensor, or automatic, and where the nerves were located. All right, some changes in their gastro system. So we talk about changes in the mouth. That includes a reduction of the volume of saliva with the resulting dryness of the mouth. You have some dental loss, which their teeth may just degenerate. They may have dentures. Dental loss is a widespread in the older population, so we understand that. Does contribute to the nutritional and digestive problems. Gastric secretions are reduced as a person ages, so it's harder for them to digest things. The incidence of certain diseases involving the bowel increases as a person grows older. Blood flow to the liver declines and the enzymes activity stop. So we know that they may have some more blood infections. All these things catch their attention. They need to go to the doctor more often. They start to have more prescriptions to them. And again, now you got all these things coming together. Those can increase the medication issues and the medication confused. And they get toxicity built up. They may have a accidental poisoning. Some poor muscle tone of the smooth muscles, like in the sphincter, between the esophagus and the stomach, can cause regurgitation and lead to heartburn and acid reflux. Alterations in absorption of nutrients and slow paralysis, weakening of the rectal sphincter, changes in the liver predispose older patients to a number of problems. I answer some other students when we're trying. Blood flow to the liver does decline, and there's a decreased metabolism. And this has a direct effect on how medications affect the patients, because this starts to have a longer breakdown when they take these medications. So it may take them, if it takes us, let's say we take an ibuprofen, which should kick in about 25 to 30 minutes. It may take 40 minutes to an hour for that to kick into the elderly patient because of the lack of enzymes that are in their acid, stomach secretions. All those things affect as how they take medications as they move forward. Some common causes of GI issues, you have inflammation, you have infection, you have obstruction of the upper and lower GI. All those are more common. So you usually have bleeding that travels through the lower digestive tract, usually manifests as milia, which is a black tarry type of stool. It kind of looks just like what the babies have on their first stool, That's kind of one of those things that you may see because you know that that's got blood in there. A patient with a GI bleeding may experience weakness, dizziness, and or syncope because of the loss of a lot of blood. Bleeding in the GI system can be life-threatening if not caught soon enough. It can cause them to bleed out. Specific GI problems that are more common in elderly patients include diverticulitis, bowel obstructions, bleeding in the upper and lower GI system, gallbladder disease, peptic ulcer disease. When assessing patients, ask about NSAIDs. Do your homework real quick. I want y'all to figure out what NSAIDs are and some alcohol use. Orthostatic vital signs can help you determine if the patient's hypovolemic. You need to make sure you understand what's going on. Those are kind of one of those things that you need to understand more of the orthostatic systems or the blood pressures, what's normal in the geriatric patients. Treatment consists of airway, ventilatory, and circulatory system. Changes in the renal system. So you may have age-related changes specific to the kidneys. You have a reduction in renal blood flow. You have the tubular degeneration. So decrease in the bladder capacity, which they're going to have to go to the bathroom a lot more often. They're going to have smaller fluid intake. So with the small fluid intake could also increase dehydration. You have a decline in the sphincter muscles, so they're going to have more accidental incontinence or release of flatulence, decreased voiding of senses, increased in nocturnal voiding, beginning prostatic hypertrophy, which is an enlarged prostate, is the functioning nephro units. This is the leading to a smaller effective filtering surface. So what that means is the renal blood flow is decreasing by 50%. So now you're going to start to have more of the UTIs, more of the renal issues, the incontinence issues. All those start to come down to where it starts to be like, oh man, something's wrong. I need to go be seen. I'm always using the bathroom. First off, everybody's going to be like, oh, well, you have a UTI, blah, 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 blah. And that's not it. There may be just some age-related changes in the system. All right, so an acute illness in an elderly patient is often accompanied by derangements in fluid and electrolytes balances. This is marked decreased thirst mechanism, which may cause a rapid development of severe dehydration. Incontinence is not a normal part of aging and can lead to skin irritation, some skin breakdowns, and urinary tract infections. As people do age, the capacity of the bladder decreases. Two major types of incontinences are distinguished between stress and urge. These stress incontinences occur during activities such as coughing, laughing, sneezing, lifting, and exercise. Urge incontinences is triggered by hot or cold fluids, running water, and even thinking about going to the bathroom can produce them to have to go more often. Come on. All right, so the opposite of incontinence is a urinary retention or difficulty urinating. I like to joke and say that's the, you got the shy bladder. But in men, you start to have the large prostate that can start to cause pressure. It is making it more difficult for them to urinate. Some bladder and urinary tract infections will start to be more prominent. They start to cause a little bit more inflammation, start to have some pain. In some severe cases of urinary retention, patients have experienced some renal failure because of that. So those are also some symptoms that they try to watch out for because they can mimic each other. Anatomy and physiology of the endocrine system. There's a significant change that occurs in an older person is decreased in their metabolism of the thyroxine. Thyroxine affects the body's metabolism, temperature, growth, and their heart rate. Most of the signs and symptoms of people experiencing are attributed to the process of aging, or goes into the ones that are on y'all's screen real quick. All right, some other endocrine changes. An increase of the secretion of a autodiuretic hormone causes a fluid imbalance. You have some hyperglycemia. This is an increasement of the neuroepi. Is it possible having a harmful effect on the cardiovascular system because of the non-epi drop? It's slowing their heart. They're going to have more issues with that because their body's wanting to just slow down. They don't have that ability. So we have to, there's a lot that can potentially go wrong with the elderly. When I say it's confusing, but the more and more we learn about that age group, the better off we are to assist them in some certain matters. Hypersolemia or hyperglycemia non-kinetic syndrome, HHNS, is a diabetic complication in older people and occur in often people with type 2 diabetes. Some signs and symptoms of HHNS and diabetic ketoacidosis, they do often overlap. You'll have hyperglycemia, polydyspia, which is severe thirst, polyuria is urination, polypelagia is hunger, and dizziness, confusion, some altered mental status, and possible seizures. On the assessment, you're going to see some changes, what you see right there on your screen. The patient may present with signs and symptoms of hypotension and shock, including tachycardia. The blood glucose level will variable in a DKA, whereas in HHNS, the value is typically about 600 milliliters milligrams, 600 milligrams or higher. DKA will present with Kussmaul respirations, while HHNS will not. So that is why I added that, is because there's the differences there between HHNS versus DKA. Well, the telltale sign is of the respirations. You will start to see the Kussmauls. You'll understand that this is not normal, what's causing this. I always highly recommend checking a sugar or CBG in an elderly patient. I've tried to get into a habit of always checking a CBG on all my patients. Sometimes it doesn't happen, but most of the time I try to do that. Your treatment should include an airway ventilatory and circulatory support. If y'all read that real quick, I'm gonna catch up on another message from Rob. So infections are very common in elderly people because they generally have an increased risk of infection, and are less able to fight infections once they occur. Many elderly patients may be unable to develop a fever, and in fact may be a hypothermic as a manifestation of a severe infection. Fatigue, weight loss, falls, and changes in mental status may be the primary symptoms of some infections in some of the patients. When infections occur, signs and symptoms may be decreased or minimized by the patient. Again, we just have to understand a broad ability, because we may or may not see every single little symptom in all of our patients. Yes, that's super confusing, and I understand that. Why is that? Each one of us are built different. We're able to understand, process, and move forward from things differently than each other. It's the same way that we are when we're children. We developmental wise, we change, and we're going to respond to things differently. Aging brings in a widespread decrease in some bone mass in men and women, but especially upon some post-menopause women. Bones become more brittle and tend to break a lot easier. The disc between the vertebrae of the spine begin to narrow, and decrease in the height between number 2 and the 3 may occur through the lifespan, along with posterior changes in posture. Joints loosen their ability to flex and may be further immobilized by orthostatic changes. A decrease in the amount of muscle mass often results in some less strength, which we get that. We know we're not going to be able to go to the gym in our 60s. Well, we may. I mean, there's a lot of more people I know in their 60s are a lot better health than I am currently at 42. So all that being said is, let's understand the muscular system and why maybe they are hunched over. Well, they've hunched over because they've lost that muscle mass, the inability to straighten themselves up just because the weight's pulling them down. They don't have anything to force against that. Changes in the physical abilities can affect older adults, their confidence, their mobility. They don't want to get out. They just want to stay at home. They just don't feel like doing it. We know their strength declines. Cartilage goes through a degenerative change. The stooped posture of older people becomes more atrophy of the supporting structures and the body. Ligaments and cartilage of the joints loosen their elasticity. That may be some causes of some falls. And then the forward and curling of the spine also is called humpback or hunchback. Those things happen more often. Again, we just said that. Why? Because of the muscle mass is decreasing. Osteoporosis is a condition that affects men and women by decrease of bone mass. We talked about that. The extent of bone loss that a person undergoes is influenced by several factors, as in genetics, smoking, their level of activity, the diet, the body weight, the alcohol consumption, and some hormonal effects. Those factors can change on a lot of things. Osteoarthritis is a progressive disease of the joints that destroys cartilage, promotes the formation of bone spurs in the joints, and leads to a lot of stiff joints. Patients complain of pain and stiffness that gets worsened with exertion, affects several joints of the body, most commonly those in the hands, knees, hips, and spine. Here's our break. We're going to take about a 10-minute. We're halfway through, so we should be about another hour or so. We should be able to knock this out. So, guys, I'll see y'all back in about 10 minutes. If y'all have any questions or anything, mark them on the screen in the chat box, and we'll address those in just a few minutes. If not, I'll see y'all at 7 or 8 after 7 o'clock. All right, let's get back at this now. Maybe if I can click the right button. All right, so we have changes in the skin. This is where we're talking about potential skin tears. So the protein that makes this skin up becomes very powerful and declines with age. You have bruising becomes more common because of the skin can tear a whole lot easier. The layer of fat that's underneath that skin also becomes thinner because of they're just redistributed better throughout the fluids and the proteins and moves things around. The exocrine or the sweat glands do not respond as rapidly to heat because of the autotrophy and changes to the tissues of the dermal skin layers. Some pressure ulcers, we know what happens if they lay down too long. The pressure from the weight of the body cuts off the blood flow to the area of the skin. With no blood flow to the skin or sores develops. To help prevent these ulcers, take special care to pat under any bony promemosis and the voids and a patient who may be immobilized for extended period of time. So you may see some ulcers when using some of the Follis various as a stage of development. You start to see, you see right there, the stage 1 through 4. The decubitus ulcers can be painful and cause complications such as bleeding, sepsis, and bone inflammation called osteomyelitis. You may see a test question every now and then to where like what type of what stage of ulcer is when you see the invasion of fat layer through the fascia. those may be some of the questions that you may come across, just FYI. So toxicology. So a lot of elderly people may have decreased kidneys and functions. You have your altered GI absorption, decreased vascular flow in the liver. You have the kidneys may go undergo many changes. We know that decreased liver function makes it harder for the liver to detoxify the blood and eliminate substances such as medications and alcohol. Again, when we start talking about toxicology, remember in the back of your mind that vision also is some of these things too, that they may not realize what all that they're taking, and they may be just the wrong medication. Some topical OTC meds used by elderly people include aspirin, antacids, cough syrups, and decongestants. Many people believe OTC medications cannot be dangerous, but they are. And these medications have negative effect when mixed with each other and or with herbal substances, alcohol, and prescription medications. They are very, very effective when you mix them and you combine them, blah, 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 blah. All those things do happen to take place. So understanding that and providing a little bit of education goes a long ways for your patient, providing some information for them, and just teaching them, maybe because they have forgotten about mixing the OTC meds along with their regular medications. Polypharmacy refers to the use of multiple medications and multiple medical prescriptions by one patient. Negative effects can include overdosing and negative medication interactions. Medication non-compliance in older patients are also an issue and may occur because of financial challenges, the inability to open certain containers, and impaired cognitive, vision, and hearing ability. Some behavioral emergencies. So a lot of elderly people go through this depression state. They feel alone. It is part of the normal part of aging, but sometimes medical issues, medical concerns affect these things. If it is treatable with medications and therapies, they prescribe them some uppers. They may try to prescribe some some mental changes. It is treatable. If depression goes unrecognized or untreated, it is associated with a larger and higher rate of suicide in geriatric patients. Some of the risk factors of depression include history of depression, chronic disease, loss. I don't know what loss means on my side. Sorry, I didn't finish that note out. The following conditions contribute to the onset of significant depression. You see on yours, you have substance abuse, some isolation. You may have some prescription medication use and chronic, let's come on, Chris Wally. Chronic medical conditions. Suicide. Most older adult suicide victims have recently been diagnosed with some depression and have seen the primary physician with or without the month before this event. Older men have a higher suicide rate than any group of age in the United States. Older persons who attempt suicide choose much more lethal manners than younger victims and generally have diminished reproductive capacity to survive an attempt. So if there is a chance that they're able to survive because of more of a lethal method, their body is just not capable to fight and try to move forward and survive that. So, and most elderly patients do have more of a sense to shoot themselves. They may have homicide, suicide. They may kill their spouse and then kill themselves because they feel like they're a nuisance on the family and our friends or neighbors. Maybe a financial reason too. Here are some common predisposing events. We talked about just their death of a loved one, some physical illnesses, depression and hopelessness, some alcohol abuse, alcohol dependence, and the loss of meaningful life roles. I can tell you, like when my grandfather and my grandmother, we had to take their keys from their vehicle and sell it because they just got to where they couldn't. That was a huge issue when we did that. I remember my dad fighting with my grandfather and grandmother about that, and how they're taking their independence away, and it was a huge ordeal. So being through that, I know that at some point in time, I'm gonna have to do the same thing with my father, and it's gonna be a huge battle that mentally I don't think a lot of us are prepared for. So taking those meaningful life roles away is going to be hard, or death of a loved one. When my mother passed, my dad had a really hard time dealing with that, and he went through a string of depression. And I'm sure there are still a little bit of times now he still has doubts of deals with a little bit of depression. When assessing the patient who is displaying signs of depression, it is appropriate to ask if he or she is considering suicide. If they answer yes, ask straight up, well, have you thought this through? Is there any, like, what's your plan? Like, and it's okay. But be prepared for any response. They may say, by shooting myself while somebody watches, and pull a gun from their waistband. You have to be prepared for those things if that is the type of situation that they're in. All right, so the GEMS diamond. The GEMS diamond was created to help you remember what is different about older patients. It serves as an acronym for the issues to be considered when assessing an elderly patient. All right, so G stands for geriatric patient. Consider the older patient as different from younger patients and may present atypical. Be very familiar with the normal changes of aging and treat older patients with compassion and respect. E stands for the environmental assessment. Assessing the environment can help give clues to the patient's condition and the cause of an emergency. Preventive care is very important for geriatric patients who may not be careful to study the environment or may not realize where risk exists. M stands for medical assessment. Older patients tend to have the variety of medical problems and may be taking numerous prescriptions or over-the-counters and or herbal medications. This is going to be gotten through a very well in-depth medical report. You asking questions, you potentially looking at their medications and asking these questions. Sometimes they may not just be coming forth with that. So S stands for social assessments. Consider obtaining information pamphlets about some of the agencies for elderly people in our area. Older people may have a need assistance with activities of daily living. Older people may have less of a social network because of death of a spouse, family members, and or friends. Special considerations in assessing a geriatric patient. Communicative issues. We talked about not being able to understand you because you talk too fast. Some hearing and vision. You guys go closer. You're blurred. You're just a blurred dot out there. I can't see you that far away. Alterations in consciousness. They may have narcolepsy. They may fall asleep pretty fast. Complicated medical histories and effects of medication because they may have taken too much. They may have that toxicity buildup. On our scene size up, some of the geriatric patients are commonly found in their own homes. You may go to a retirement home. You may go to this nursing home, but you're going to assess them to be maybe hampered if their condition prevents them from getting to the door. You take notes of a negative or unsafe environment conditions. You're going to look for clues that might explain the patient's medical history or current problem. If they are in a nursing home or a residential care facility, you need to locate the patient's room and find a staff member who can explain why you were called. And a lot of times it's because they don't want to deal with them, and it's right there as they're coming on to new shift change. In any case in which a patient's mental status is altered, you need to find someone who can tell you the patient's history and whether the patient has a behavioral or level of consciousness is normal or altered. So the NOI may be very difficult to determine in elderly patients because their mental status is probably going to be from dementia or Alzheimer's. You may ask the family member or caregiver why he or she got called. Multiple and chronic diseases may also complicate the NOI. Chest pain, shortness of breath, and altered level of consciousness should always be considered very serious, because remember, we're talking about potential pneumonia. Those are one of those that we have to be cautious about. Primary assessments, we're going to do address life threats. We're still going to think about our ABCs. We're still concerned about those because our circulation is, if they're bleeding, they're going to bleed out quick. Determine the transport priority of the patient based on his or her condition and maintain a high index of suspicion for serious injuries, even with mechanisms of injury that might seem minor to the younger patient, but they're more severe in our elderly patients. As you approach the patient, you should be able to tell if the patient is generally in a stable or an unstable condition. Use of APU scale to determine the patient's level of consciousness is a very good tool to use. Aging and disease can compromise a patient's ability to protect his or her own airway with the loss of a gag reflex and normal swallowing mechanisms. Ensure that the patient's airway is open and is obstructed by dentures, not obstructed. Ooh, I read that completely wrong. We want to make sure it's not obstructed by dentures, vomit, fluid, or blood. And if it is, we need to make sure we have our suction on us and it's handy so we can suction that airway out. So you may have some anatomic changes. It talks about their affectability to breathe, because remember those, the lung muscles and then the chest wall muscles, they're weaker. They're not able to push all that fluid out like we can now. The loss of mechanism that protects the upper airway, such as a cough and gag reflexes, is caused to decrease by clear secretions. They're going to cough and they're going to get congested. They're going to have a worse effect to food in the mouth or food in the throat. Airway and breathing issues should be treated with oxygen as soon as possible and be considered a need for rapid transport if they are having issues with just breathing on a normal basis. There's no reason why we shouldn't provide them a high flow oxygen and still continue our assessment. There's no reason why we can't do that. Circulation, lower heart rates and weaker and irregular pulses are very common in elderly patients. Vascular changes and circulatory compromise makes it very difficult to feel a radial pulse in an older patient. Circulation problems in older adults should be treated with oxygen as fast as possible. Determine if cardiac abnormalities in an elderly patient indicate an acute emergency, or is this something that's chronic that they deal with all the time? Or is this an acute emergency and should we manage it pretty rapidly? We don't want to wait around. So transport decisions. It's your decision on what you want to do. You guys will be the new EMTs out there. You'll be the ones that are having to make these decisions. So if you say it's a rapid transport decision, okay, we'll rapidly transport them. And then somebody judges you like, oh, I wouldn't have transported them like that. Well, you weren't there to make that decision, but I did it based off of blah, 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 blah. And you know what? That's okay. Because again, we talk about like triage. We're all going to triage somebody and patients differently. But I've learned through life lessons, why try to quarterback something when you weren't there to make that decision. So they saw something that they thought was a rapid transport, and that's what you decided, and you stuck with it. If you make the decision to do a rapid transport, and then you're like, hey, control or dispatch or Syncom, whatever you want to call them, you guys, we need an ALS intervention. It's still your call. What happens after that? It's not your problem. It's up to the paramedic that gets there. Some history taken. Let's ask as much as we can, as soon as we can. Now, again, this may not be something that we get from the patient, but we can get from like a status sheet from the nursing home, or the nursing or the assisted living has these sheets that they can tell you. But if you go to the elderly patient's home and they stay by themselves, we may not be able to get all the information that we need. But if a family member shows up, let's still ask them a lot of the questions too, to see if they can pass that information along. It's very beneficial. A sample history. The chief complaint may be related to a chronic medical problem, or maybe something that's off the wall acute problem. Obtain a list of the patient's medications or what that they currently take. Take the list. You don't have to take all the medicines if they have everything written down. Transport to a facility that knows the patient's medical history if you're possible. If you can't transport them to, I don't know, Cincinnati General and they're from Mississippi, I'm not transporting them all the way up to Cincinnati. It's just not going to happen. It's just going to be a new patient. Surprise. But what we need to know is what the last oral intake is very important with a patient with diabetes, because this is potentially going to indicate the patient may be dehydrated or they're not following their proper meal plans, and they may just be malnourished, which is causing them to be have hypoglycemia. So on our secondary assessments, we know all these should be done while we're en route to the hospital. Your older patient may not be comfortable when being exposed, so remember that. And tell them, remember what it said earlier, tell them what you're going to do so we can do it in the right way. Consider the need to keep your patient warm during the exam, because most of your elderly patients are going to be cold. They're going to stay cold. So remember, we have to keep them as warm as possible to keep their blood flow going, that they don't get cold and start shivering. Then they'll start vagling down. All these issues start affecting the reasons. So the warmer than more comfortable that they are, the better off we're going to be in the long run. Our vital signs. We know we want to make sure we take continuous vital signs. Circulatory compromise may be difficult to feel a radial pulse in an elderly patient, and the pulse points may need to be considered. Because remember, now you're talking about the hardened blood vessels. They're going to have that buildup. You may not feel them as well. As you see on yours, the medications such as beta blockers keep the heart rate low and prevent tachycardia from commonly being seen during dehydration and or shock. So it's really hard to teach you guys what beta blockers are and how to recognize, because there's so many beta blockers out there. But if the family or if the patient says to you that I'm taking a beta blocker, just know that they're going to have a decreased heart rate on the get-go. So when you look at them and you check their vitals and they have a heart rate of like 50, that may be their normal pulse rate because of that beta blocker. Blood pressures tend to be higher in elderly people. Capillary refill is not a very good assessment because of the skin changes, and it does reduce circulation to the skin. The respiratory rate should be in the same range as a younger adult, but remember that the chest rise and fall will be compromised by increased chest wall stiffness. Those muscles lose their elasticity. Carefully interpret of a pulse oximetry may be necessary in elderly patients because of the pulse oximetry device requires adequate diffusion to get an accurate reading. If their hands are cold, you're not going to get an adequate reading. It's just not going to work. So if you can keep the patient warm, put it on their finger underneath the blanket so they can have that tool can have a normal reading. Again, reassess your patient, a geriatric patient. They may and very much will deteriorate just like the pediatric patients do. If you did something as an intervention, recheck it. Always keep an eye on there. Identify and treat changes in the patient's condition and make notes. If you got to make a mental note, do that. Or if you write it down, that's fine. You have to add that into your report at a later time. Just document our history of medications, assessment, and intervention information. Those are all a part of your report standing. There's just a chart on some guidelines for assessment. Let y'all look at that for a second. I'll take me another drink. Right. All right. So some trauma in the geriatric patients. In general, the risk of serious injury or death is more common in older patients who experience trauma than in younger adults. Conditions that create risk and complicate the assessment of geriatric patients. You have slower hemostatic composition. They start to have trouble clotting earlier. Obviously, I can't say the word. Limited psychologic nerve responses, normal effects of aging on the body, and some existing or pre-existing medical conditions. Some physical findings in older adults may be more subtle and easily missed. The healing process does take a lot longer. So these may be in the hospital a lot longer because of their injuries. Older people are more likely to experience burns because of the altered mental status, inattention to the compromised neurologic status. Risk of mortality from burns is increased when they have a pre-existing medical condition. Their immune system is weak, which we already know that their immune system is weak because we've talked about how aging of like the neurons are 50% less. All of these things, so we know automatically they're at a decreased survivability. I guess that's what we want to call it. There is a higher mortality for penetrating trauma in older patients, especially in the case of a gunshot wound. Penetrating trauma can easily cause serious internal bleeding. Falls are the leading cause of fatal and non-fatal injuries in older adults. Hint, 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 I would know that. Nearly half of all fatal falls in geriatric patients result in traumatic brain injuries. Changes in the pulmonary, so cardiovascular, neurologic, and muscular systems make older patients more susceptible to trauma. The brain shrinks, leading to higher risk. And cerebral bleeding and followed severe head trauma. The brain does shrink, loss of strength, sensory impairment, and medical illness all increases from the risk of falls. A geriatric patient's overall physical conditions may lessen the ability of the patient's body to compensate for the effects of multiple simple injuries. Osteoporosis predisposes older patients to hip and pelvic fractures. You see right there, yours talks about some contributing factors. All those are big, big signs of some issues that patients go through the older that they get. Compression fractures of the spine are more likely to occur due to the stiffness. Things become more brittle. Even though they're stiff, you start to have the osteoporosis and things become a lot more brittle. Because the brain shrinks when aged, older patients are more likely to sustain closed head injuries, such as a subdural hematoma. Serious head injuries are often missed in older patients because the mechanism may seem relatively minor, or an acute subdural hematomas are among the deadliest of all head injuries. Other factors that predispose an older patient to serious head injuries include long-term use of alcohol, recurrent falls, or repeated head injuries. What's Muhammad Ali? He had issues with that. The head injuries because of the boxing history. If y'all ever got to watch the movie, I really enjoyed Ali. To me, that was a great movie. That was his thing. He didn't have a drug problem nor alcohol, but he had repetitive head injuries. So that caused a lot of traumatic and affected his like stroke levels and all that. Some environmental injuries. Changes in the endocrine system results is delayed internal temperature regulation. They always cold. This is the way you can remember. Heat gain or loss is further delayed from impaired circulation, decreased sweat production, chronic disease, medication use, and alcohol use. Half of all deaths from hypothermia occur in older people. Mostly indoor hypothermia deaths involve geriatric patients. Some death rates from hypothermia more than double in older patients compared with younger people older than 85 years or highest at risk. Trauma is never isolated to a single issue when you are assessing and caring for a geriatric patient, because they're gonna have a multi-system issue. Just because it's a gunshot doesn't mean it's just that particular, it's going to affect the entire area. So let's talk about our scene size up. Bystanders may inform you of help. Look for clues that indicate whether your patient's traumatic incident may have been preceded by a medical incident. Address your life threats again. Determine the transport priority of the patient. It is recommended that older trauma patients be transported to a trauma center rapidly. Form your general impression like we always talked about. Use your AVPU scale, use your Glasgow-Coma score. What is your triage? Triage them and see what is going on. If you believe, again, it's a rapid transport, rapidly transport them. Get them to that trauma center. Airway and breathing in older patients are going to be diminished. And the ability to cough and suction is going to be utmost important because you need to clear that airway. They are having already issues and going to clear it. Assess for the presence of dentures, but do not remove them unless they create an airway patency problem. Leave them in place because I've known people that have pulled them out and left them on the ambulance and they got lost. So, and that's a very big issue for the geriatric patient. Circulation, drinking alcohol and taking anticoagulant medications that can make internal bleeding worse or external bleeding much more difficult to control. That can happen in our age. We can have issues with that. You know, both of those are going to create you to bleed a lot more. So patients who are hypertensive prior to the injury may have a normal blood pressure when they are actually in shock because the body's compensating. So when they say that they have high blood pressure and you're like, are you like 120 over 80? That's like great. But remember, if they say that they're hypertensive, go off of what they say. They know their bodies. And a lot of them know their medications. Some of them may not. I don't know what I take, but they may. Investigate the chief complaint. Listen to them and let them know that you understand them. Let them feel that you're paying attention to what they're being said. Be symptomatic about what's going on. Understand, be like, no, it's okay. I'm glad you called the ambulance. You know, we're here to help you. Sometimes the elderly continue to call because we are the only ones that listen to them. Sometimes we may know, hey, Miss Earl, how you doing? What's going on tonight? Oh, she's diabetes. Okay, all right. Well, what hospital are we going to tonight? All right, Miss Earl, I'm gonna go get your bag at the back. You ready to go? We've been there so much, but don't take those repetitive calls lightly because sometimes those repetitive calls can burn you and turn around and something serious can happen to that patient. Physical examinations should be performed on geriatric patients in the same manner as any adult, but consider of the higher likelihood of damage for any type of trauma. When examining the chest, consider that breathing is going to potentially be impaired. Remember, because we talked about the elasticity is wearing out. Any head injury can be life-threatening in an older adult. Look for bruising and stages of bruising. Vital signs, one thing I can say here is just continue to take those over and over. And remember about the beta blocker. Those are going to become an issue if they tell you they're on a beta blocker. Reassessment, reassess them on the way to the hospital. If they have a broken bone and you splint it, continue to monitor it. Here's they talking about they're placing a pad underneath the void space. It appears by this picture she has broken her left hip. You can see that it is shortened. It's hard for her to put it down. It is uncomfortable for her to even lay on that side. That's why they've got her on her right side, and her leg is being padded in the void area. Communication and documentation. Provide as much information as you can. Obtain any type of treatment that you've done, what you found, how you found it. All that information is just as important to be passed on to the medical facility and to go into your report. You got to add that information, and getting all the information you need ultimately also affects the way that you get paid. So if you get paid through their insurances, you got to get that information so you can bill them. All right, so response to a nursing home and care facilities. Many calls will occur at a nursing home or other skilled care facility. Now, I'm not sure how we'd say skilled, but calls to these types of facilities can sometimes be very challenging. Patients often have an altered level of consciousness and may need to be able to give you a nature of illness or a mechanism of illness. The most important piece of information you need to establish immediately is what is wrong with the patient and what is different today, or what has caused you to call me now. Talk to the staff who directly care for the patient and on a daily basis. I always say this to most of the time you have a little CNA that comes down there, and those are the ones that actively take care of the patient, but they're required to have a nurse over their care. Not being disrespectful to the CNAs, but I always require the nurse to come down and speak with me. It is something that I like to have the nurse speak to me at their bedside and provide all the information that they can. The reason why I do the bedside is because I like to watch the patient's response on what the nurse states. That lets me know their ability to understand things. And if they say, if they're talking out of their head, or they're just, that's not right, that that's not, those things help me understand the patient's cognitive ability. Some infection controls, remember Staphylococcus, however you want to say that, but that's MRSA. The organism can be found in decubitus ulcers, on feeding tubes, and on indwelling urinary catheters. So how to protect yourself is to reduce the spread of MRSA is to wash your hands before you go in and after every patient contact. Dispose of all your disinfecting all your medical equipment. Take appropriate standard precautions with every patient. Many infections in hospitals are caused by VRE. I'm not going to try to pronounce that one. Or the respiratory virus called RSV causes an infection of the upper and lower respiratory. The virus is highly contagious and is found on discharges from the nose and throat of an infected person. Always wear, and they have contact isolation information on some of these doors. And then again, I like to ask, hey, do we have any contact isolation as we go inside? Nope, you're clear to go. All right, but if you get to the door and you realize, man, this got a contact isolation on it, that's something that is required for them to put there, because that is such a highly contagious thing. A lot of your nursing homes don't like to have MRSA patients there because of how severe that they are. But due to the systems and all that, they have to treat those patients there. Some of the other infectious controls, that's not really, you don't see those a whole lot. SARS-CoV-2, this is another strand of COVID. We know that SARS is out there. I saw today that the first transmission of the bird flu was found and somewhere in China today. I was like, oh Lord, here we go again. We know we're still dealing with some of the COVID-19. It's not as prevalent as the pandemic as we were going through, but it is still out there. I'm not sure what virus we are on now, but remember to protect yourself. Even if you don't feel comfortable about going in somewhere without a mask on, put it on. So what? It's okay. You do you. Advanced directives. So each state is different. Each agencies take them differently. You need to know about what advanced directives are. Ask your agency what we do with them in such and such situations. How do we treat that? What is the requirement? But in advanced directives are specific legal papers that direct relatives and caregivers about what kind of medical treatment may be given to patients who cannot speak for themselves. Prime example, I have a power of attorney that goes into place for my wife to have over me if I'm unable to speak. I have one over my wife in that situation, and we do have advanced directives in case something happens. I do that because of how I get to work. The flying to and from work is the most dangerous part of me being out here. So in those situations, if something was to happen, we have some medical paperwork already in line. I suggest many people do that, but not a lot of people want to go that route. It is stressful to think about, but it is worth it in the long run. Advanced directives may take the form of a do not resuscitate or a DNR. A DNR order gives you permission to do not attempt to resuscitate a patient that is in cardiac arrest. For a DNR order to be valid, it must be signed by the patient for legal surrogate and by one or more physicians or other licensed healthcare providers. A DNR does not mean do not treat, but if the patient is still alive, you are obligated to provide supportive measures that may include oxygen, or pain relief and comfort. A healthcare provider of attorney is an advanced directive that is exercised by a patient who has been authorized by the patient to make medical decisions for him or her. I was just telling you all about my situation. Another type of order is a PLOST, a physician's order for life-sustaining treatment, which gives medical orders in addition to the advanced directive. Orders may be specific to a person who has a life-threatening condition or is in frail health. If there is a question regarding orders or when there are no written orders, initiate resuscitation. I know in my area, DNRs have to be redone every 90 days because they expire. If you are given the DNR, you cannot have a copy of the DNR. It has to be the original, and this goes to my area. I know what my EMS says and what the Central Mississippi protocols require. So, and if a family is present and they do have a DNR, ultimately every family member needs to be in agreement of things. If they are not, you need to advise them, y'all are unable to confirm this DNR. If that's the case, I will have to work Mr. Fred and do CPR and advance. I put a tube down his throat, blah, 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 give narcotic drugs and all that. Are y'all okay with this? If one of them says no, I want all of it done, even though there's an active DNR, my order, my area, we have to go with those wishes. Now, you can also call your med control for more advice, and they can give you those informations to help you make a better decision. Elderly abuse is the same thing that we're going to talk about about children and pediatrics. We need to look at their person, property, and emotional state. Those issues can become from result of acts of omission such as denying an older person adequate nutrition or medical care. It's the same thing that happens in pediatric patients. Elderly abuse is a problem that has been largely hidden from society. They don't want to see that. Nursing homes that may not have family members down there may also be a part of that. Victims of elderly abuse are often hesitant to report the problems to law enforcement agencies or human and social welfare personnel. They just don't want that information out about them. So that's one of the things that's hidden. Victims of elderly abuse are often hesitant to report the problems to law enforcement. And we said about the abused person may feel traumatized by these situations or be afraid that their abuser will punish him or her for reporting the abuse. Abused person is often frail with multiple chronic medical conditions or dementia. Elderly abuse occurs most often in women older than 75. Abusers of older people are sometimes products of child abuse themselves, and the abuse that is inflicted on the older person may be in retaliation. Environments such as nursing homes and continuum care centers are also sites where older people sustain physical, psychological functions and pharmacologic harm. Be suspicious of an abuse when to answer questions about what caused the injury are concealed or avoided. Suspect abuse when you're unable to get a clear and precise answer. Caregiver apathy about the patient's conditions, overly defensive, reactive by the caregiver, repeated visits to the emergency department or clinic. You have a history of being an accident prone. Oh, well, they just constantly fall out of bed, or you have unbelievable, vague, and inconsistent explanations or injuries. Well, this is what happened, and that's what they said on night shift. And it's just like, well, those don't add up. I've come and got Mr. Fred for the past 6 months, multiple times while I've been on the ambulance. So, well, they're like, does he keep getting bruised? I mean, what's the deal? So you're never given those adequate answers. You have self-destructive behavior, you have depression or lack of energy. Many patients who are being abused are so afraid of retribution that they may make false statements. They may go into agree with saying, yeah, I slide out of bed, I try to get up and do things on my own. They tell me not to do it, but I do it. So they're trying to hide it so they don't get any retaliation from it. Here's some of the categories we look at: physical, psychological, and finance. Theft of valuables, embezzlement is a big one because they play on their, I don't know how you put that. They play it on their just ability and their vulnerability, and they give them these sob stories and they take a lot of money from them. Signs of physical abuse, we look the same exact thing that we look for in pediatric patients, except here we're going to see more of cheek or earlobes, neck injuries, upper lips, inside of the mouth from things hitting them in the face. Human bites are typically inflicted on the upper extremities and can cause lacerations and infections. Pressure bruises caused by the human hand may be identified by oval, glove, pinch mark, or handprints. Those will make you very aggravated. I can promise you that. I've seen those. Inspect the patient's ears for indications of twisting, pulling, or pinching, and the evidence of a frequent blow to the outer ear. Investigate multiple bruises in various states of healing, and the appearance of being undernourished. Sorry, I can't. And there's several more on your screen right there. Again, these have to be told to the nursing home when you transport them, and by law, we as caregivers have to report those to the state if you don't transport them to a facility, like a medical facility. It is well worth it when you just potentially suspect these things, call med control and just be like, hey, listen, I've talked to my doc. They really want to take them. They really want to get them over to the hospital. And they're like, oh, I'll go with you. No, sir, ma'am, we don't allow riders. I'm sorry. That's just part of our policy. I do that a lot. I don't like people in the back of my ambulance, or in the front of my ambulance with my partner. So I constantly say that that's against our policy and our insurance won't allow it. You can see there, hygiene's a big one. Reasonable for lack of amenities in the home. Maybe a family member supposed to be paying their bills and they don't have power because it wasn't paid. That's a lack of amenities. In regards to the genitals or rectals with no reported trauma and evidence of sexual abuse in any patient, if they have maybe a swelling to those particular areas, you may see tenderness or bruising to the genitalias. Those are some of the issues that you may see from sexual assaults. Specifically in men, they may pinch, pull, or twist the testicles. I know that that's been some in one of the areas the lady is now in prison for. She abused multiple men and women throughout the facility through sexual abuse. Does anybody have any questions? This is the end of the chapter. Just to let you guys know, this is also our last chapter. We are done for the portion of the class. It's been a good one. It's great. I've had blast with you guys. Also let you know, I am not going to be taking the EMT classes anymore. I will not be teaching them. I am moving on up to the EMT advanced class. I've kind of got some more people there, and I need to step up to teach there and have some other people to be teaching the basic class. So y'all are my last basic class. But it's been fun. It's been real. I understand that y'all may have got aggravated sometimes, and some time delays, but it's been a really good class. I've enjoyed it. I'm glad to have had y'all in my last class. You've been quiet a lot, but I've learned a lot from you guys, speaking to y'all on the sides. But your lecture will open tonight. You need to make sure you take that. I will be passing on information about your finals that are coming up in the next upcoming days. So paying attention to Discord. And if y'all don't have any questions, y'all want this right here. This is your class code for the night. I know y'all are glad to type that in, but that is your class code. And again, hope y'all have a good night. Good luck on your test. If I don't talk to y'all again, good luck on your final. I wish you all the best. And I hope to see y'all in our advanced class soon. Good night. Y'all have a good weekend. Stay safe, and we'll speak to y'all through Discord again. Good night, y'all.